So all of you can hear my slide?
Yes, sir.
Okay. So this is our knee. So basically 3 bone. You all know that. Femur from above, tibia from below, and front is your patella. So now I'll be adding the other structures. So first I'll be talking about the muscles, ligaments, then nerves. So these are the 3 important areas. So first let me talk about the muscles. Okay. And also let me put the ligaments as well. Let me enlarge it. So first we'll start with the anterior knee. And for the anterior knee, so we normally divide it above the patella, suprapatellar area, and below the patella, the infrapatellar area. Suprapatellar area, what we'll be seeing? We'll be seeing the quadriceps tendon. This is the quadriceps tendon. And we all know the 4 muscles. That is why the name is quadriceps. The topmost muscle is your rectus. And if you're removing the rectus, then the 3 vastus. One is your vastus intermedius in the middle, vastus lateralis, and vastus medialis. So now they are the 4 muscles from anterior side. If I am coming to the medial side, the very important medial side, 3 muscles, we call it as pes anserine muscle. So they are sartorius, gracilis, and semitendinosus. Semitendinosus come from posterior to the medial side. So we'll be looking the semitendinosus at the posterior side as well. So this is the medial side. And if we are going the posteriorly, so posteriorly very important is your hamstring muscles. So there are 4 hamstring muscles. So semimembranosus below, it's bulky, and semitendinosus, as we can understand, it is mostly tendinous in the knee. And on the, this is the medial side, 2 muscles, 2 of the hamstring muscles. And on the lateral side, so above is your long head of the biceps femoris, and below is your, this is your, the short head of the biceps femoris. Remember that when we'll be looking at the knee, then long head of the biceps femoris becomes almost tendinous. It is shorter. It lies above the short head of the biceps femoris. So these are the important muscles. Apart from that, very important is they are the 2 heads of the gastrocnemius, the medial head and the lateral head of the gastrocnemius. And you know, when you look at the Becker cyst, normally it comes between the semimembranosus and the medial head of the gastrocnemius. In between, this Becker cyst bulges out, and we should go and from the posterior medial side like this, we can go and inject into the Becker cyst. So these are the muscles. Now let me remove the muscles layer, and then we'll be coming into the ligamentous part. Okay, another important muscle I forgot to mention. There is a short muscle there, and this is known as the articularis genu muscle. This articularis genu muscle, you see how it is getting attached. It is getting attached with the suprapatellar recess, the synovial recess. Get attached, and it do not allow it to get impinged between, because it pulls the recess up so that it is not impinged between the femur and the patella. So there are few bursa. So one of this bursa is the prepatellar bursa. So prepatellar bursitis is common. Then there are 2 bursa which is called intrapatellar bursa. One is superficial. This is your superficial, and this is your deep. One superficial is above the patellar tendon, and deep is below the patellar tendon. So quadriceps muscles, quadriceps tendon, they get attached with the patella, and then they are extended below to get inserted into the tibial tuberosity. So then this part is known as the, so let me put the muscle there again so that you understand that the patellar tendon. So this was the patellar tendon. So the patellar tendon or patellar ligament, both is the name. So this bursa is inferior, the inferior intrapatellar bursa, which is superficial intrapatellar bursa. And another is your deep intrapatellar bursa, which is below this patellar ligament or patellar tendon. So this is your on your medial side. This is your intrapatellar area. Intrapatellar area, another very important ligament is a deep ligament, which is your the ACL ligament and the PCL ligament. ACL ligament anteriorly and PCL ligament posteriorly. I'll be coming to that ACL and PCL ligament later on. But before that, few other ligaments is important. One is your medial collateral ligament. This is the medial collateral ligament. Medial collateral ligament again has two bands. One is your superficial band, another is your deep band. And this is your medial, the retinaculum, medial patellar retinaculum. And this is your patellofemoral ligament. So medial patellar retinaculum is basically the extension of this is vastus medialis muscle. It is extended as a medial patellar retinaculum. And below that, arrangement, look at the arrangement. This is your patellofemoral ligament. This patellofemoral ligament, I am enlarging it. So patellofemoral ligament is horizontal. This is patellofemoral ligament. And medial collateral ligament is again vertical. So these three layers means superficial layer is your the patellar retinaculum, which is extension of the vastus medialis muscle. Then next layer will be your patellofemoral ligament. Though it is looking as a very short medial patellar retinaculum, basically it is not that short in the reality. So it will be extending little more beyond till the medial collateral ligament. So it will be getting intermingled with the medial collateral ligament, this patellofemoral ligament, sorry, and above that patellar retinaculum will be there. So when we'll be coming to the medial side of the bone, medial side of the joint, we'll be able to see the three layers. The superficial most layer, which is the patellar retinaculum, which will be continuous with this vastus medialis muscle. And then we'll be coming the patellofemoral ligament, which is intermingled with the superficial layer of the medial collateral ligament, and then the deeper layer of the medial collateral ligament. The deeper layer of the collateral ligament again will be having the two part. One is your meniscofemoral part, and another is your meniscotibial part. Meniscofemoral is going above meniscus to femur, and meniscotibial is your meniscus to tibia. So this is your medial patellar retinaculum. And if you're going laterally, so this is your lateral patellar retinaculum and your again patellofemoral ligament. So superficial one is your the patellar retinaculum, and then there is your the patellofemoral ligament. And this same patellofemoral ligament is basically when we are coming down below this retinaculum, we'll be able to see the patellotibial ligament. Patellofemoral is here. This is patellofemoral, and there is patellotibial ligament, which is not shown here, but that is below the patellar retinaculum. So medial patellar retinaculum, there is a continuous ligament. One is your patellofemoral, another is your patellotibial ligament. And if you are going more medially, then what will happen? The patellofemoral ligament will be continuous with the superficial layer of the medial collateral ligament. So now coming to the posterolateral part, this is your the lateral collateral ligament. Lateral collateral ligament is getting attached from where to where? From the tibial, the head, fibular head, sorry, till the condyle. And there is another ligament which is not shown here, is your Gardis, which is originating from the Gardis tubercle, that is your iliotibial band. So from here it will be going above, and iliotibial band, you know, that what is getting inserted in the iliac crest, and where earlier day we discussed that the gluteus maximus and the tensor fascia lata, they are the two muscles which are getting attached to the iliotibial tract. So iliotibial tract will be originating from the Gardis tubercle. So now lateral collateral ligament, and then again this is one head, one ligament. This is called arcuate ligament. Basically, this is a Y-shaped ligament. There is a lateral band and there is a medial band. So here again, it is originating from the head of the fibula and getting attached into the either into the meniscus or into the tibia. This part is inserted into the meniscus. This part inserted into the condyle, femoral condyle. So you see there are continuous different ligamental structures, and these ligamental structures are basically nothing but thickened part of the joint capsule. So now if I am removing all these part, so again, here is another, let me remove the capsule. Then what we'll see, this is your oblique popliteal ligament. This is a very tough structures, oblique popliteal ligament. And oblique popliteal ligament is very, hyperechoic, bright structures. So if I'm hiding this hyperechoic bright structure, Then what is important here, this ligament is your posterior cruciate ligament. So posterior cruciate ligament, you see, it is almost vertical. Posterior cruciate ligament, where it is getting attached, posterior cruciate ligament is getting attached into the medial side of the lateral condyle of the femur. You see, it is getting there. And this is being enclosed by this ligament. This ligament is what? Meniscofemoral ligament. So this meniscofemoral ligament again has two parts. One is your Humphreys part, another is the Risberg part. This is a Risberg part. And if I'm tilting there, there is another part that is your Humphreys part. Anterior part or Humphreys part of the meniscofemoral ligament. See here from it is originating. It is originating from the meniscus. Let me remove this part, arcuate ligament. This was arcuate ligament, Y-shaped arcuate ligament. If I'm removing that, so from the meniscus, this ligament is getting originated. This ligament is what? This ligament is the meniscofemoral ligament, posterior the portion, or posterior portion is also known as your Risberg portion. So this is going horizontally to enclose the posterior cruciate ligament. This is the posterior cruciate ligament, and this is posterior. The Risberg part is posterior, and anterior to that there is another part of the meniscofemoral ligament. Sorry, it was here. So that was your Humphreys part or the anterior part of your posterior cruciate ligament. Now, if I'm going anteriorly, anterior cruciate ligament is there. So let me remove all those things so that you will be able to see the anterior cruciate ligament. So let me remove this. This fat pad is known as the Hoffa's fat pad. This is your Hoffa's fat pad. So now if I'm removing this Hoffa's fat pad, then we will be able to see one ligament here. That is the transverse ligament of the knee. This is again very important part, that the transverse ligament, below the transverse ligament, there will be a ACL ligament. Let me remove the ACL ligament. Was not seen. So ACL ligament starts from here and it goes below the transverse ligament, transverse meniscus ligament. This is the transverse meniscus ligament. So, and it get attached to the lateral condyle, medial part of the lateral condyle. So these two are the stabilizers of I'm unable to show this anterior cruciate ligament from here. So it goes from there is a V-shaped structure, depression here, and this go below the transverse meniscal ligament. I don't know why it is not shown. Okay. Anyway, so this was from the anterior part, and the ligamentous part. Posterior also I show. Medial part, the medial collateral ligament I already told. Medial collateral ligament, medial patellar retinaculum, and patellofemoral ligament. So these are ligaments. Then let me remove these layers and let me talk about some of the nerves there. Okay, this ligament, anterior cruciate ligament, is seen nicely from the. Okay, so this 3D anatomy is not very perfect. Basically, this anterior cruciate ligament is being covered by the transverse meniscal ligament. This is the transverse meniscus ligament. So, or the transverse ligament of the knee. It comes below, and that is one of the landmark how to identify the ACL. So now let me put the nerves. So the very important nerve is the sciatic nerve. Let me put the nerves. So sciatic nerve is getting divided into what? The two important tibial nerve, which comes down vertically and which goes laterally, is your common peroneal nerve. Common peroneal nerve, it comes down and it comes to the head of the fibula, where it is getting divided. After that, getting divided into superficial, what is that? The deep and the superficial peroneal nerve. And then there are two other important nerves there. One nerve is the medial sural cutaneous nerve, this one, and lateral. This is lateral supracutaneous nerve, and there is another supracutaneous nerve, that is the medial supracutaneous nerve. These two nerves will be able to identify it. The medial supracutaneous nerve originates from the tibial nerve, and the lateral supracutaneous nerve will be originating from the common peroneal nerve. So these are apart from these nerves, there are few other very tiny nerves, which is not shown in this 3D anatomy, is the different genicular nerves. So the superior medial, superior lateral, and inferior medial. These are classically these three nerves, genicular nerves, are targeted always. But we have to remember a few other nerves which also supplies the knee joint. What are those nerves? So on the medial side, the nerve to the vastus medialis, which is there in the adductor canal, which also contributes to the joint capsule. And saphenous nerves, particularly the intrapatellar branch of the saphenous nerve. They also supplies the medial and the intrapatellar area of the knee joint capsule. So medially, what are the nerves? So medially, 4 nerves. Nerve to vastus medialis, superior medial genicular nerve. I'm talking in order. From the top, we're having the nerve to vastus medialis, which will be giving supply. Next is the superior medial genicular nerve. Then is your intrapatellar branch of the saphenous nerve, and then is the inferior medial genicular nerves. So these are the nerves from the medial side. What are the nerves from the lateral side? So one of the nerves is as we know, that the superior lateral genicular nerve. But again, nerve to the vastus lateralis also contributes to the joint, but nerve to vastus lateralis is very difficult to identify by the ultrasound or any means, and frequently it gets missed. So nerve to superior medial genicular nerve supplies the lateral part of the superior lateral genicular nerve, supplies the lateral part. But again, it has one of the very important branch, which is lateral reticular branch. So lateral reticular branch supplies the lateral, inferior lateral part of the joint capsule. So here one anatomical things we should be remembering, that lateral reticular nerve is a branch of superior lateral genicular nerve. So superior lateral genicular nerve gives off the lateral reticular nerve. Now this lateral reticular nerve supplies the inferior part of this lateral part of the joint capsule. So what is important to know here, if we are blocking the superior lateral, normally the lateral reticular nerve should be getting blocked, but not always. Sometimes this divisions comes much earlier, much higher. Then what will happen? The lateral reticular nerve might be spared, and the infralateral part of the joint capsule may not be denervated nicely. Apart from that, another nerve is your recurrent fibular nerve. So recurrent fibular nerve also can be traced both here at the level of the Gardis tubercle, or here from where it is originating, just above the. So the lateral side, what are the nerves then? Lateral side, the nerves are nerve to vastus lateralis, superior lateral genicular nerve, lateral reticular nerve, and recurrent fibular nerve. So again, 4 nerves from the lateral side. So these are the 8 important nerves which supplies the knee joint capsules. And most commonly, we target the superior medial, superior lateral, and the inferior medial, because these are the 3 nerves which are easily accessible, and it is accompanied by the blood vessels. Sometimes nerves are seen, sometimes nerves are not seen, but the blood vessels are seen. And we can target these nerves easily. But keeping in mind that there is a high chances of failure of the, if I are targeting only these nerves, because the many other nerves are there, which is also supplying the knee joint capsule. So I'll be showing you some of the nerves, not all the nerves, but many of these nerves I'll be able to show on the volunteer today. So these are the today's topic, what I'll be volunteers. If anybody wish to know anything before I am starting with the volunteer, ask me.
Sir, can you please repeat the difference between the medial and the lateral ligaments?
What?
Sir, the difference between the medial and the lateral ligaments. Medial and lateral ligaments.
Ya, saya Dr. Bius, Dr. Alex. Saya yang akan bagi, Dr. Chan akan bagi cucuk jarum semua. Saya bagi salah satu ialah bagi dekat
Okay. So medial side, okay, let me put the ligaments or let me draw the ligaments. Okay, that will be better. Let me draw the ligaments because the 3D anatomy is not always foolproof. Many times there are problems. So vastus medialis, sorry. So after the vastus medialis there, after the vastus medialis there, so one of the ligament there, that is the most superficial layer, that is your medial patellar retinaculum. It comes vertically down. Below that layer, there is another layer of the, I'm putting it the different color, that is your medial patellofemoral ligament, which is there also on the lateral side, that is known as lateral patellofemoral ligament, which is deeper layer, which is deeper. And then on the medial side, this ligament, patellofemoral ligament, is continuous mix up with the superficial layer of the medial collateral ligament. Medial collateral ligament extends up to here, pes anserinus tendons. So after that, there is a third layer of the ligaments, which is the deeper layer of the your medial collateral ligament. So deeper layer of the medial collateral ligament has two parts. One is your from the meniscus. Let me put another color. So from the meniscus to the femur, meniscofemoral, and meniscus to the tibia, that is your meniscotibial ligament. Clear? So most superficial layer is your continuous with the vastus medialis, that is your medial patellar retinaculum. After that, from the anterior side, we are having a ligament that is known as patellofemoral ligament. Patellofemoral ligament is a horizontal which gets intermingled with the superficial layer of the medial collateral ligament. And then below that, third layer is only there on the medial side, not on the anterior side. That is your second layer or deeper layer of the medial collateral ligament, which has two parts, meniscofemoral and meniscotibial.
Yes, sir.
Is it clear?
Yes, sir.
Okay. Now, if you are going to the lateral side, we are having the same, the patellofemoral ligament, and above that is the lateral patellar retinaculum. And this patellofemoral ligament is continuous with the lateral collateral ligament. Okay? Clear?
Okay,
Third
sir.
layer is not there in the lateral side. And if you are coming below the patella, intrapatellar area, then also there are two layers. Superficial layer is your retinaculum and deeper layer is your patellotibial ligament. The name is changing. Above, it was patellofemoral medial or patellofemoral lateral, but below the patella, it is coming patellotibial ligament. Patellotibial ligament will be like this. Okay?
Thank you, sir.
Clear?
Yes, sir. Yes.
Okay. Anything else? Anybody wish to know? We'll be able to see whatever I talked, we'll be able to demonstrate all those things, all the ligaments, all the nerves. Muscles are very easy, but all the nerves and all the ligaments also I'll be demonstrating. So if no question, let me clear the things and let me put the muscles again. Nerves, I am just reviewing for time being. Okay, this was your iliotibial band. This was the iliotibial band. So first, what I'll do, I'll be holding my probe here at this level. So if I'm holding the probe in this layer, what we'll be getting? We'll be getting the quadriceps tendon, and on the medial side, vastus medialis, vastus lateralis, and below that, we'll be getting the suprapatellar recess and few of the fat pads. And after that, we'll be holding it in the longitudinal section, and then we'll be coming medially, in interpatellar area, both in this way, and then medial side, and then on the lateral side, and then posterior side. Okay, so without delay, let me start. So all of you can see?
Yes, sir.
Okay, so series is there. You are
Yes,
not
sir.
there.
I'm here. I'm looking. I was 2 minutes late, sir.
2 minutes late. And I didn't see Milton also.
Yes, sir. Yes, sir.
He's also here, sir.
Milton also, how many times, how many minutes late?
Sir, 8 minutes, sir.
8 minutes, okay.
Sir, actually, I am not actually informed that today is the MSK class. So far,
You are going to demonstrate the pathology today.
so just I am overview these things.
Okay.
Actually,
I'll be taking another 1 hour. By that time, you complete.
yes, sir. Okay. Okay, sir.
Because today I am going to Malaysia. I told last week, and that is the reason why I will not be available tomorrow to demonstrate. And that is the reason why I am taking the MSK class today instead of tomorrow.
Okay, sir.
Okay, so knee will be approximately 30 to 45 degree flexed for this anterior knee. So you see what I'm doing here. So my aspect marker is towards the proximal side. So aspect marker is on this side. And that is this side of the screen is your left side of the screen. And this side of the screen is your right side of the screen. So if I'll be getting the picture like this. Let me increase the gain a little bit. So what you can see here, this is the home page. So first layer is, this is your, after the skin, subcutaneous tissue, then is your quadriceps tendon. Quadriceps tendon, the first tendon, first which becomes tendinous is your rectus. And last to become tendinous is your vastus medialis. After that, this is your, okay, this is one bone. What is that bone? This bone is your patella. And this bone is your femur. After that, here we are seeing some hyperechoic structures. This is your suprapatellar fat pad. After that, there is a black area. This is your suprapatellar synovial recess. So it is an extension. It is not a bursa basically. It's an extension of the suprapatellar, the suprapatellar synovial recess. After that, there is one layer of the muscles. And this is another fat pad. So this fat pad is the prefemoral fat pad. This is your articularis genu muscles. Okay? So fix it in your mind. The home page. What are the structures? Everybody is able to understand? I'm showing you again. Let me decrease the depth a little bit so that you'll be able to appreciate better.
Sir, your video is not in the center, sir.
Not in the center. Means?
We are unable to see where you are putting the probe on the knee.
It was like this. Okay. So one end, distal end of the probe was on the patella. So this is patella. This is patella. So this is the, the base. This is the apex, the base. So my Distal end of the probe was over the patella and proximal end proximally towards the quadriceps. Is it clear? Can you see it?
স্যার একটু ক্যামেরা উপরটা করলে ভালো হবে স্যার।
ক্যামেরা একটু উপরে দিয়ে করতে হবে?
হ্যাঁ একটু অল্প স্যার।
আচ্ছা ঠিক আছে।
অল্প। একটু একটু উপরে স্যার। ঠিক আছে এখন মাঝখানে আছে। ঠিক আছে স্যার, এটা ভালো আছে স্যার। দিস ইজ গুড স্যার।
Okay. So now everybody understood what I have demonstrated. So this is your quadriceps. Again, I am showing this is quadriceps. After the little small amount of the fat, subcutaneous tissue, small amount of the fat, the quadriceps. Then this was your hyperechoic structure is your patella. This is your the femur. This is your suprapatellar fat pad. This is your suprapatellar synovial recess. This was your articularis genu muscle, and this is your the prefemoral fat pad. Is it clear to everybody?
Yes, sir.
Yes sir.
Okay. So now I'll be holding the probe in short axis. So again, my aspect marker is towards the left side. That means left side of the screen is the lateral side. Left side of my screen is the lateral side. So if I'm flexing a little bit more and I'm holding it. Can you see? I'm holding over the patella. This is the shows the patella. Everything is bone. And then when I coming here, I'm in the intercondylar area. And this is one of the area where we have to understand whether osteoarthritis is there. So this is the hyaline cartilage. We discussed many times that the hyaline cartilage looks hypoechoic. And after that, there is the quadriceps tendons are there, and we are having this is your extension of your synovial recess. So now I'm going from here, I'm going above. So I'm going above. So what we are seeing here? Okay. So what we are seeing here? This is your vastus medialis. As we told, vastus medialis becomes tendinous at the last. This is a little bit of vastus lateralis. So vastus lateralis becomes tendinous before vastus medialis. Then there is a synovial extension. Another one thing is to remember that the femur, the lateral part of the cortex is elevated. It's like that. It is never horizontal. Always remember that. So this was the prefemoral fat pad, and this muscle is your articularis genu muscles. This was your prefemoral fat pad, and this is the quadriceps tendon. Here another very important structure to remember. This hyperechoic area is what? Is your iliotibial band. These hyperechoic structures. And here, another hyperechoic structure we can see is the short head of biceps. This area, basically. So, short head of the biceps, not long. Long head biceps is more posterior. So these are the structures at this view. Okay. So let me clear it and let me show you again. So I was here first. After that, I was going up. When I'm going up, I can see the synovial recess. I can see even here, you can see the synovial recess goes very nicely. Above one layer of the fat, suprapatellar fat pad, below one layer of the fat, and this black area is the muscle, articularis genu muscle. So this is again better seen even. So let me see it here. So this is the articularis genu muscles. This is your prefemoral fat pad, synovial recess, suprapatellar fat pad, and there is your tendon. Some part of the muscular part is also seen. Here is the vastus medialis muscles, vastus lateralis muscles, And here is your, not very nicely seen, will be your the iliotibial band, and here is your biceps femoris muscles and tendons. Now I'm going still up. From here I'm going still up and look at the things what is happening. So now the myotendinous junctions. So you can see at this position the 4 muscles we can see. So what are these 4 muscles? Again, this muscle was your the vastus lateralis. This muscle is your vastus medialis. This muscle is your the rectus, and this is your the, so it's like figure of 8. This muscle is vastus intermedius. This is your rectus femoris. Rectus femoris becomes the tendinous first. Okay, and then this one, and then this one. Let me clear it. Okay, from here, I'm going up. What I told you, remember, the lateral side will be elevated. So you can see all the layers going up, and gradually you can see all the 4 muscles, and then becoming tendinous. See tendinous. So you can see the tendons, except vastus lateralis medialis, medial 2 muscles has become tendons. And here below articularis genu muscles, which is also very nicely seen here. This is your articularis genu muscles. Articularis genu muscles. And if I'm coming little lateral side, you can see the iliotibial band. This is the iliotibial band, and here is your rectus muscle. Okay, so this is your the anterior knee suprapatellar area. Is it clear to everybody? Can I come to the intrapatellar area now? So
Yes,
this is the patella. Above that is your the very thin bursa. Unless there is a bursitis, it is difficult. This is already told. You see where I am putting the probe. This is your prepatellar bursa. There are different names are there. This bursitis. So that will be covered by Milton. Housemaid's knee, clergyman's knee, all the different names are there. But again, anatomically remember, that is your prepatellar bursa. Then I'm coming below. I'm in the long axis. So I'm holding the long axis. Let me increase the depth a little bit. So what we can see here. So again, let me draw. So this was your patella. This was your the tibia. So after the skin subcutaneous tissue, this is your patellar ligament or patellar tendon. So here there will be very thin bursa. That is your, not seen here nicely. That is your superficial intrapatellar bursa. And again, here another bursa will be there. That is your the deep intrapatellar bursa. Deep intrapatellar bursa, little black line is sometimes seen here. Let me see whether it is seen here in this volunteer or not. Seen, you see? Little bit of fluid is normally seen in. Okay, so this is your this black area. This is your deep intrapatellar bursa. It is normal. Very small amount of the fluid is can be seen, and if you see abnormally high, then it will be your the bursitis. Here there is no bursitis, no correction of the fluid. So again, look at the other part. This part is your Hopper's fat pad. Hopper's fat pad has 2 layers. One is your superficial layer, another is your deep layer. Deep layer, you can see there is a line. Superficial layer characteristics is your the heterogeneous. Deeper layer is homogeneous. Superficial layer is just like a packing substance. Deeper layer is basically gives the elasticity, and some of the studies are there. In fact, we also started one study to see if there is any relationship between the deep layer of the Hopper's fat pad and the osteoarthritis knee. But still again, the relationship is still not clear till now. So again, let me show you. I'm keeping the neck like this. So the bone, what you can see here, deep to that is your femoral condyle. Means this bone. This bone is a femoral condyle. Let me. So this one. And above that, a small homogeneous area that is your the deeper layer of the Hoppus pad. But superficial layer of the Hoppus pad, a lot of sticks are there. And very commonly mistaken is this is your ACL, this is your ACL. Those are not ACL. I'll be telling you how to see the ACL. So first you understand the layer. Let me repeat. This was your patella. This was the tibia. This is your tibia, the ligament, the patellar ligament or patellar tendon. Here will be a small bursa, that is your intrapatellar bursa superficial. Here is will be one bursa, which will be the interpatellar bursa deep. This is your Hoppus pad superficial layer. There will be lots of sticks are there. So now I'll be showing you the ACL. For seeing at the ACL, you have to make the knee flexed. So again, I have to calculate this one. I have to again change my camera, otherwise I can understand that you are unable to see it. Okay. Knee should be maximally flexed, otherwise you won't be able to see. So now, if with this flexed knee, if I'm holding the probe like that, let me put lots of gel. Okay, now ACL is very nicely seen. So let me draw again. This small hyperechoic area is your, what was this? This was your patella. This was your tibia. This hyperechoic fibular structure is a patellar ligament. This is your Hoppus pad. Now try to understand two important structures here. One is this one, a hyperechoic cross-sectional area. Can everybody understand this? Hyperechoic cross-sectional area, where I am putting the dots. Everybody can understand?
Yes, sir.
So that is known as that, and the depth of it will be approximately 2 centimeters. So you cannot see the centimeter area here, but if you are measuring, it will be approximately 2 centimeter cusp, little less than 2 centimeters. So that is your cross section of the transverse meniscal ligament, as showing in the 3D anatomy. This is the cross sections, and this hypoechoic structure bounded by two hypoechoic structure. This is your ACL. I'm removing the drawing so that you can appreciate it nicely. So ACL is always looks hypoechoic. Why? Because it is deep and going down. And that is the reason why echoes will not be coming back to your transducer. So it will be looking hypoechoic in this view. It will be looking hyperechoic. I'll be showing you on the transverse axis. But now I'm seeing the long axis. So now this is your ACL. And this is your transverse meniscal ligament. So what is important? To search the ACL, you should search the transverse meniscal ligament. And it will be starting inferior to that. And you will be able to find it out. Again, I'm saying. So, how to hold the probe? Longitudinally, I'm holding the probe. And one side is your tibia, another side is your. So, now the transverse ligament is your very bright white. Can you appreciate that? At the depth of approximately 2 centimeters, can you appreciate this white, bright white?
Yes, sir.
That is your transverse ligament. And can you appreciate something hypoechoic coming down here?
Yes, sir.
That is your ACL. Clear? Everybody understood ACL? Say yes or no.
Yes,
The
sir.
superficial part of the ACL is looking a little bit hyper. After that, it is looking hypo. And now you show another very important part. ACL has two portions. One is your anteromedial, another is your posterolateral. Now ACL is so nicely seen. So now I am just moving the foot. Now the ACL will be becoming hyper and hypo. Can you appreciate that? I'm rotating the hip, I'm rotating the leg. Can I appreciate the movement of the ACL? ACL is very nicely seen. Sometimes it's becoming completely hypo, sometimes it's part becoming hyper. Okay, so ACL we have seen in the long axis. Now we'll be seeing the ACL in the short axis as well. So if I'm putting the short axis probe like this, what I'll see? I'll see the AV above the tibial plateau, and there horizontally you'll be able to see the what? Horizontally, this is the V. Horizontally, you'll be able to see the transverse meniscus ligament. Okay, let me treat it here. So what can you see here? So this was your patellar ligament or tendon. Okay, so this is the V or what you should search for. And after that, this is your the transverse patellar ligament, transverse meniscal ligament, and this hyperechoic structure. It's not only one part is seen. There is a little bit of more part is here in this. So this part what is seen very hyperechoic is your posterolateral part, and anterolateral part. Normally both cannot be seen hyperechoic together. So here you can see the posterolateral part, and anteromedial part will be here. This part. I'm showing you again. And I'll be tilting the probe, and you try to understand both this part of this ACL, anteromedial and posterolateral. So I'm unfusing it. So I hope everybody can understood that the layer by layer. The superficial is your most superficial layer is your, now it is seen very nicely. So patellar tendon. So after that, this is your transverse meniscal ligament. Little bit of hoppus pad will be seen, very thin layer. And now the ACL is completely hypoechoic, not seen at all at this position. But why I have fused it here, because now the transverse meniscal ligament is your very nicely seen. Transverse meniscal ligament, this hyperechoic and hypoechoic structure above. And this hyperechoic part is a part of the ACL. So that is always you should be remembering that not all the structures will be looking hyper or hypo at the same time. So at this position, I am seeing the transverse meniscus ligament very nicely, but the cross section of the ACL is not seen nicely. But now if I am tilting the probe, so now at this V, if I am tilting the probe, so now this is your part of your ACL. Now it is looking partnership. Now it is looking. So this part is your ACL. Okay. Everybody understood it? So you should search for this V. In this V is your middle part of the tibial plateau, from where it is originating below the transverse meniscal ligament. Okay, I hope everybody understood the ACL very nicely, both in the long axis as well as in the short axis. Yes or no?
Yes, sir. Sir, the probe position is a little bit tilted, not exactly horizontal.
I was tilting the probe to see it. I am tilting the probe to see it, the different structures. I told you, no, not all structures will be seeing hyper or hypo at the same time. So I was tilting the probe. You see now, okay, now it's sitting so nicely. So this is the two part of the ACL, and this is your transverse meniscus. So I am splitting the probe just to, okay, is it clear? And this part is this part is the transverse meniscus ligament. And this part is your anteromedial part is now seen. Posterolateral part is not seen now. This is your posterolateral part again. Okay, so now the two parties again very nicely seen. Anterior and the posterior. Anterior is little bit medial side, anteromedial, and the posterolateral side. And above that, the ligament is here. This ligament is here. This ligament is here. The transverse meniscal ligament. This one. This one. Okay, clear. Now I'll be coming to the. Nobody is telling yes loudly. If you are not sure, I am ready to show it again.
Yes, sir.
Okay. Now I have to adjust the camera again. বুঝে বলেছিলাম এখানে থাকতে। Okay, so let me put again a lot of gel there. Otherwise, these are bony part, less muscles. So now if I'm holding the probe like this, first you see what you can see here. So what you can see, this is your what? This is the lateral side. That is your tail. Everybody is silent. Somebody at least tell what is that bony part? That is bone, no? And see, I'm holding the probe.
No, Patella, sir.
Patella. So why are you silent? And what is this? This bone?
It's a femur.
Femoral condyle. Medial. This is your patella. Okay. So now here, try to understand two very distinct layers of the ligaments here. What I discussed there. One part is your superficial part. Can you appreciate that? And below that, there is another part. Can you appreciate? And both the ligaments are quite thick. Superficial part and deep. Okay, I'm drawing, and then again, I'll be removing the drawing so that you can understand that. So, one part is this part. And another part is, I'm putting dot. You remember ligaments are always normally sagging, lax, not tight like tendon. Can you appreciate the two layers? I'm reviewing the drawing again, and you just try to understand. Can you appreciate? The superficial layer is much more bright white, and below layer is little darker, but still hyperechoic fibrillar pattern. Can you appreciate, everybody?
Yes, sir.
The superficial layer is your medial patellar retinaculum, and deeper layer is your patellofemoral ligament. This is your patellofemoral ligament, and this is your patellar retinaculum. And this is quite thick. This is your this is your patellofemoral ligament. Whole area I am making color. Everybody could have understood, and in between there is a hypoechoic area. Everybody can understood the two layer. And remember, the superficial layer, when you are having problem in identifying it, so superficial layer normally go above and below. So superficial, camera adjust করে হচ্ছে ক্যামেরাটা আমাকে বারবার উঠতে হচ্ছে আচ্ছা এখন ঠিক আছে so let me increase the depth a little bit. Let me decrease the depth a little bit. Okay, so what is this muscle? I'm holding like this. What is this muscle I told? One side patella, one side femoral condyle. And what is this muscle?
Vastus medialis.
Very good. Vastus medialis. Now look, see what is happening. Vastus medialis, I'm coming down. Vastus medialis becoming thinner. And now it is continuous with the patellar retinaculum. And below that, there is a layer which is the patellofemoral ligament. Very nicely seen the two thick layers. It is quite thick. Don't struggle. So this is your very thick layer of the patellar retinaculum. Very thick, whole of this. In between there is a hyperechoic fibrillar. And this layer this layer is your patellofemoral ligament. This is this below, and above is this one, quite thick. Everybody understood it?
Yes, sir.
Say yes. Okay,
sir.
now this black area is the synovial disease, which is coming. So one of the option of giving the injection, particularly when there is no fluid, you can come like this and inject here. Okay, by piercing the medial patellar retinaculum. And this is particularly done. So knee should be extended like this and a little bit of like this, rotate externally, and you'll be getting this picture. And that is one of the options when you don't have any fluid there under ultrasound guidance. Is it clear to everybody?
Yes, sir.
Okay. So now my probe was like this. Now what I'm doing, I'm holding the probe like this longitudinally. And now, okay, sorry. So my aspect marker is on the little bit of flights. And let me put again dot objects. So now, if I'm holding the probe like this, you can see the joint, you can see the meniscus there. So this is your medial meniscus. This bone is your tibia. This is your medial condyle. And here also you try to see the 3 layers very nicely seen. So most superficial layer, this one. What is this layer?
Retinaculum.
Retinaculum. Very good. After that, there is another layer, this one. What is this layer? On the medial side, this is
ligament.
patellofemoral ligament, now continuous with the superficial layer of the medial collateral ligament. And now deeper layer of the medial collateral ligament is your meniscofemoral and meniscotibial. Clear? Try to see it again. I'm drawing with the clearly drawing. So one layer, second layer, just in front of the joint line it is thin, but again becoming thicker above and below. And another layer is this one. Everybody can appreciate this 3 layer, very seen, very nicely.
So,
1 layer, 2 layer, 3 layer. Everybody can appreciate.
yes, sir.
So these are the 3 layers when we are in the medial part of the knee. Let me clear and let me unfreeze and let me solidify. So I was here. Try to understand the 3 layers very nicely. And if I'm going above the superficial layer, see here it is again very nice. You can see the 2 layers above, below. The middle layer is the superficial layer of the collateral ligament. And if I'm going above, the superficial layer will be continuous with the vastus. You see, vastus medialis. It is continuous with the retinaculum. So this is a retinaculum, continuous with the vastus medialis. And below that another layer, and 3rd layer will be coming only here, in front of the meniscus. Okay, now let me come down. One of these. Let me come down. So what you can see here, this superficial layer coming down, coming down, coming down, coming down. So now what you can see here, below, you see small laddu. These remains here.
Yeah. Itu lama.
Please, all of you remain muted, otherwise there is a lot of disturbances there, please. Okay. Can you see the superficial layer of the medial collateral ligament and below there the medial, inframedial genicular nerve? Sorry, genicular artery, calcium.
Yes, sir.
So this was your hyperechoic, this is your the superficial layer of the medial collateral ligament. And here we see the three tendons, space sensory tendon. 1, 2, 3, space sensory tendon. Everybody can understand this section of this space sensory tendon is here.
Ambilkan mas box size and adjusters ini ada.
Sir, can you make me co-host
Dapat,
so that
dapat.
I can mute other people?
Saya dah bagi diagnostic PCM. You ambil kat morphine, bagi dia 3 mg, 4 mg.
Alex, you are talking too much.
Okay. Sorry.
Okay. So again, let me come here. I was here. So superficial layer of the medial collateral ligament, and it is coming there, and we can see the space sensory tendon there. So this is the medial part. Okay. At the same time, inferior medial genicular artery I have shown you. Inferior medial. This was the inferior medial genicular artery pulsating nicely. And normally it should be done, injection should be done in the long axis. Long axis of the artery. In this view. Okay, and superior medial genicular artery. And now look at the center of the screen. Something bouncing. Can everybody appreciate?
Yes, sir.
Over the cortex, something is dancing. That is your superior medial genicular artery. And just medial to that, nerve is also seen very nicely. Just distal to that. So sometimes nerves are seen, sometimes this is your nerve, and this was your artery. Again, I'm showing you. Look at that area very nicely. Can I appreciate the nerve very nicely? The hyperechoic structure just distal to the artery. Can
Yes,
everybody
sir.
appreciate?
Yes, sir.
Just adjacent to the artery. So that is the nerve. And here also, inferior medial also, you have seen the artery. Nerve is also seen very nicely. See, here, just distal to the artery, you see something, hyperechoic structure. Just adjacent to that is moving when I'm tilting the probe. Look at the artery at the center of the screen. And just distal to that, can you see something hyperechoic structure, honeycomb-like structure? Look at here. This was the artery, and this is the nerve. This is the nerve. This is the nerve. Just I'm tilting the probe. Just try to understand. Can everybody appreciate that hyperechoic honeycomb appearance structures? Just distal to the nerve. That's distal to the artery. That is the nerve. But for doing the procedure, you have to do it in the this angle. Doing the procedure is difficult. You have to normally make it like this, long axis of the artery, and then you'll be able to do it better. Okay, so this is the medial side. Now come to the laterals. And then I will go into the posterior. For the lateral side, okay, everybody can see the knee.
Yes, sir.
Do I need to adjust the camera or it is okay?
It is okay, sir.
Okay. So here, two important structures are there. One is, if you are palpating it, here is your tibial fibular head. This is one fibular head. and this is your Gardis tuber. So these two are very important structure. From the Gardis tuber, something will be coming like this, that is your litival band. And from the here it will be coming something like that, that will be your lateral collateral. So first let me hold the probe on the gut from the okay. So let me freeze it here. So this is your lateral collateral ligament. This was your fibular head. This is your fibular head. This is your tibia. This is your condyle. And this thick hyperechoic structure is your lateral collateral ligament. Can everybody appreciate? Very thick ligament, nothing to miss. Don't think that this medial lateral collateral ligament are very thin structures, quite thick structure. Everybody appreciate it?
Yes, sir.
I'm showing you again. So one end of my probe was over the fibular head. So palpate the fibular head here. So this side is your fibular head on the right hand side, and on the medial side is your, in between is your tibia, and left hand side is your condyle. So and in between we are having the lateral collateral ligament. Okay, so now what I'm doing, I'm putting the probe over the Gardis tubule. So this is the Gardis tubule, and this is a very nice iliotibial band. Just please store this image in your hard disk of the brain. So this is what is your the Gardis tubule, and this is your iliotibial band. Little bit hypoechoic, bounded by two hyperechoic line, and little bit of fibrillar structures in between. So this is your iliotibial band. Are you following the iliotibial band more proximally? Just follow it. First, you look at here. Try to understand. Fix this image. Okay, everybody appreciates. Everybody appreciates. What is this structure? This is your popliteal tendon, which is getting originated from this fossa, and this is your lateral meniscus, and this is your iliotibial band. If I'm going above, see the iliotibial band, this is the iliotibial band, and this is the area where the iliotibial band syndrome, because it is getting impinged when the knee is flexed and extended. So this is the area where iliotibial band syndrome will be getting the hypoechoic area, and that is the most painful area. So I have shown this area on the above the patella also. And here again, the vastus lateralis muscle. So it will be going above the vastus. So again, this is your iliotibial band. And this is your popliteal muscles, tendon, not muscles, origin. This is your the lateral meniscus. Is it clear to everybody? Iliotibial band and lateral collateral ligament. Is it clear to everybody?
Yes, sir.
Okay. So now two more things I'll be showing you. Here is your superior lateral genicular artery. Can you appreciate it here?
Yes, sir.
And just distal to that is the nerve. Everybody is appreciating. I'm not freezing it because otherwise you will not be able to see the pulses.
Yes, sir.
Superior lateral genicular artery accompanied by the nerve. Nerve is also seen very nicely, hyperechoic honeycomb structure. Everybody appreciates the nerves also. Superior lateral genicular nerve. Now, two other nerves. So I told you, one is your the lateral genicular nerve. Another is your recurrent fibular nerve. Recurrent fibular nerve will be seen in the two areas. One is your, this was what I told you. What is this? I told you to store in the image in the hard disk of the brain.
Iliotibial band.
Huh?
Iliotibial
band. Okay. So it, sorry. Here is decreased. So if I'm coming down coming down here. Let me put some gel. You'll be able to see some pulsation there. And that is one of the area where the recurrent. So you have to come down here. So body tubercle is here. Can you see some pulsation in the middle of the screen here? Say yes or no.
Yes, sir.
So that is the arteries just below the Goddess tubercle. This side was Goddess tubercle, was your the iliotibial band was there, no? This was the proximal side, left hand side. Now I'm coming down and search the artery there. Okay, everybody can appreciate the artery there. So that is the recurrent pleural nerve. But recurrent pleural nerve also seen in the another area. So again, what I'm doing, I'm putting the probe over when I saw when I saw the lateral collateral ligament at that position, look at some pulsation here at this area. Can you see some pulsation here? Can you see pulsation here? And this is the recurrent pleural nerve here also. Very tiny. So it can be blocked here as well. I'm holding the book, changing the orientation a little bit. Okay, so you just hold the probe when you are seeing the lateral collateral ligament. You can see the very nice lateral collateral ligament. From this side is your fibular head. This white hyperechoic structure is your ligament. So now you'll be seeing the nerve here and you'll be seeing the artery there. Can you see the artery now? Pulsating, nice. This is the artery. If I'm tilting it, it is going away. Okay, very small artery, and it will be accompanied by the nerve. So this is one nerve, and another nerve will be there. This is easy to find out. Here is the artery, and here is a nerve. That is your lateral retinicular nerve. The nerve, artery, and that distal to that is your. This is the artery, and distal to that is your lateral retinicular nerve. Can everybody appreciate these two nerves? This is better seen, and
Yes,
this is small artery and accompanied by the nerve. So these are from the lateral side, lateral knee pain. These 4 nerves can be targeted. 4 nerves name, the lateral nerve to cluster, the lateral is difficult to identify. Okay, another thing I forgot to mention on the medial side, that was the adductor canal, and another important nerve is the saphenous, along with that the saphenous intramedullary gland at the saphenous. So let me increase the depth a little bit. So here I have to find out at the middle of the thumb, I have to find out the sartorius muscles and the femoral artery. Everybody can appreciate this.
Yes,
So
sir.
what are the structures here? Many of you are anesthesiologists. I'm sure all of you are doing these things. So this muscle is your sartorius muscle. Sartorius muscle is basically triangular, boat-shaped muscle. This muscle is what? Tell. This is your femur. What is this?
Dr. Magnus.
Adductor magnus.
No. Adductor magnus is here. Longus and magnus.
So
This
what's
is
this?
justus medialis.
Medialis.
Justus, this is the femur. I told you, no, this is femur. So this is your justus medialis. This is your sartorius. This is your adductor, and this is your adductor canal. So this is the artery, and here is your nerve. Okay, you'll be able to see the two nerves. You know the two nerves. Nerve to vastus medialis and here, you can see the two nerves. 1, 2. Again, I'm unfreezing it. So this is your femur. So the muscle next to it is your vastus medialis. If I'm going here, now I can see. Everybody can appreciate now?
Yes, sir.
Okay, so now follow this. I am coming down. So what is happening? So these nerves are going above. Follow these nerves here. The nerve to vastus medialis will be going medially. I'm just following this muscle which nerve which is there on the medial corner of the sartorius. Below and the medial corner of the sartorius. Here. So this is the one nerve, and here is another nerve. This is your intrapatellar branch. I lost. So adductor canal block is done here. You have to come, needle should be coming like this, and it will be going, injecting here. I'm just trying to place the nerve. Artery goes down. So here two nerves are very nicely seen. One, this is your interpatellar branch, and this is your main saphenous nerve. This one. At the medial corner of the sartorius. So now this nerve, this is your interpatellar branch. This comes very superficial. This one. This comes very superficial, very superficial. So when it will be coming closer to the nerve, then some artery will accompany. Some artery you can see, now artery has accompanied the nerve. So now the medial condyle. After that, it becomes very tiny and difficult to trace. Now still it is seen, but it will I'll be losing once I'm coming over the condyle. Still it is seen there, there. And after that, it will be coming below the patella. Okay, so that was the intrapatellar branch. I forgot to mention on the medial side of this. Medial side, these are the nerves. Okay, now let me go to the posterior side. The knee is little bit of extended, hyper extended. Otherwise, it's difficult to show the different structures. So you remember lateral side two muscle, medial side two muscle. Lateral side, what are the two muscles? These are the two muscles. So this is one muscle, this is another muscle. So this is superficial one is what? Lateral side. Two muscles, lateral side. What are the lateral side two muscles? Please unmute yourself and tell. Am I audible?
Yes, sir.
Lateral side, what are the hamstring muscles? No, there are 4 hamstring muscles.
The rectus.
Biceps.
Biceps femoris.
Sorry, biceps
So the
femoris.
2 head of the biceps femoris. This is your
Long
long
head.
head. Superficial one is long head. Deep one is your short head. Okay. So if I am going below the, again, look at here. If I'm going above, both the heads are almost equal. And if I'm coming down, you see, the long head is becoming shorter, short head is becoming larger. Can you appreciate? If I'm going above, the long head is becoming larger, short head is becoming shorter. This is almost horizontal, 2 lines, but this is little bit of elliptical. This is your long head, this is your short head. Can everybody appreciate?
Yes, sir.
Okay. And at this junction, this is your sciatic nerve. Can everybody see the sciatic nerve also?
Yes, sir.
Now let me go to the medial side. For the medial side, what do you see? There is semimembranosus and semitendinosus. So see what is happening? There are 2 muscles. One was this semitendinosus, and this is your semimembranosus. So I'm going above, you see, semitendinosus becoming more and more muscular. And this is your semimembranosus. Like this. You know, it's like a pot. This is a large circular area and a small part of the tendon there. It is becoming now completely tendinous now. Okay. So this is your semimembranosus. This is your semitendinosus. If I'm going more medial, you see, there will be another muscle. This one. This is your gracilis muscle. So this was semitendinosus, partly muscular, partly tendinous. This is the gracilis. And if I'm going more here, what is this muscle? You can say?
Sartorius.
Sartorius.
Yes, very good. So these are the three combining together, becoming the face and serum. One is your, this is your sartorius, this is your gracilis, this is your semitendinosus, and this is your semimembranosus. So these are quite separated now. Here, 1, 2, 3. If I'm going distally, you see the keeping the gracilis in the middle. You see from the other side, the semitendinosus is coming, and sartorius will be tendinous last. See? Now, at the medial part of the tibia is getting tendinous. All 3 tendons are now close together. So here it was muscular. 3 tendon, the 3 sartorius, gracilis, semitendinosus. Now you see another way to look for it. So because sartorius muscle is very nice, always very easy to see because it's a boat-shaped muscle. You see, this is the muscle. So now I'm making it long axis. Long axis. Long axis. Now you see sartorius muscle in the long axis. This is the proximal side, this is the distal side. And now I'm coming distally. See what is happening? It is becoming tendinous. Tendinous getting attached in the medial part of the tibia. And if I'm coming here, another tendon, gracilis and semitendinosus. And at this point, I already shown you, these are the 3 tendons. Okay. 1, 2, 3. 1, 2, 3. So this is the medial side. And I can see this semitendinous in the long axis also. Over the semitendinosus. So this was your semitendinosus, this is your semimembranosus. So now I'm coming distally. Semitendinosus will become tendinous fast. So now semitendinous is tendinous. Semimembranosus is also becoming tendinous. And now it will be dipping down. This will be your further. It is getting attached to further. So this part is your tibia. This is your femur condyle. So the 2 tendons are coming and dipping down here. So superficial one is your semitendinosus. This is your semimembranosus. Okay. I'm tilting the probe. Head to maneuver. Then I can heel to maneuver. Then I can see the 2 tendons nicely. 1, 2. So this was your medial side, and this was your lateral side. Lateral side, I told you, short head and long head. And here was your sciatic. Now follow the sciatic nerve very nicely. This was your sciatic nerve. Hole is big sciatic nerve. And now if I'm coming down there, see, now it is getting divided. One is superlateral, another is inferior medial. So this part will be becoming tibial now, and this part will be becoming the common peroneal now. Can you see this getting separated? Let me decrease the depth so that you can appreciate it nicely. Okay, so initially it was one, and now when I'm coming down, becoming 2, 1 and 2, 1 and 2. And now lateral supracutaneous nerve is originating here. This is your common peroneal, this is the lateral supracutaneous. See, it is coming here, this one, and this is your lateral supracutaneous nerve. This is your lateral supracutaneous nerve. And this is your common peroneal nerve. I'm coming distally. This is your common peroneal nerve. Common peroneal nerve. Common peroneal nerve. This was your lateral supracutaneous. And now common peroneal nerve at the head of the femur. The head of the femur. See, now it will be getting wrapping around the neck, going to the lateral compartment, lateral side. Can everybody appreciate the peroneal nerve, common peroneal nerve?
Yes, sir.
Okay, so I was here. Now I'll be following. So this was the common peroneal, this was your tibial. I'll be increasing the depth a little bit. Now, this is your tibial nerve. Now follow the tibial nerve now. Common peroneal and tibial. Now tibial nerve will be dipping down. And one nerve is going, that is your medial. This nerve is your medial supracutaneous, and tibial nerve is dipping down here. See, tibial nerve is dipping down here, and it is coming superficial to the popliteal. So this was your medial supracutaneous. This is your tibial nerve, dipping down, dipping down, dipping down. Can everybody appreciate? Some nerve is going again, the muscular branch is going away. Can everybody appreciate?
Yes, sir.
So again going up here. So this is the tibial, follow the tibial. So first medial supracutaneous nerve will be separated there, going above. And this is the medial supracutaneous, and this is your tibial. Tibial is coming down, and becoming on the top of the popliteal artery. Okay, everybody appreciated this. So now on the medial side, I forgot to mention one. So between the semimembranosus, so semimembranosus and semitendinosus, you remember this? This was semimembranosus, this was semitendinosus. If I'm coming little down, so this was your semimembranosus, and on the medial side, we'll be seeing so this is your medial head of the gastric means. So this is your semitendinosus. So normally through this, the Becker's cyst will be coming and bulging between these two, means semimembranosus and the gastrocnemius. So from here, the Becker's cyst will be bulging out. Okay, now one thing is left, that is your posterior cruciate ligament. So for that, I have to increase the depth further. Okay, I'll be changing the probe also, because this probe is very high frequency probe. I'll be going to the 12 megahertz probe, which will be, I'll be able to show you better. Okay, so see what I'm doing first. So remember, the posterior cruciate ligament is like this, and this is bounded by 1 and 2 anterior and posterior, the Risberg and the Humphreys ligament. Risberg is posterior, Humphreys is anterior. So first, when I'm holding, okay, I forgot to mention another important ligament, arcuate ligament. Arcuate ligament, I'll show you later. First, you see the cruciate ligament. So here, when I'm holding the probe like this, so what is this? This is your medial femoral condyle and the cartilage. Can everybody appreciate it?
Yes, sir.
Okay. So now what I'm doing, look at my probe position. I'm going more lateral side, lateral side, lateral side, lateral side. Then the condyle is vanished. Now I'm in the intercondylar area. Intercondylar area. So now at this position, okay, let me hold the probe. Okay, so this was the condyle, femoral condyle, medial femoral condyle, and a little bit of tibia is also seen here. Okay, this is a meniscus, medial meniscus. So now what I'm doing, I'm sliding the probe medially, and gradually, medial condyle will vanish. Once the medial condyle is vanished, and then I'll be coming here. This is very, very important. Hard disk of your brain, you just fix it. Okay, so what is this? This is your tibia, tibial plateau here. This is your intercondylar area of the femur. And this is your PCL, hypoechoic. PCL is again hypoechoic because it is slanting down. And PCL is bounded. This is your popliteal ligament, oblique popliteal ligament. This white, let me draw, and then I'll be removing the drawing so that you can understand it nicely. So this was your intercondylar area of the femur. This is your tibial plate. This is your PCL. This is your posterior part, cross section of the Humphreys, the Risberg ligament. This is your oblique popliteal ligament, very thick oblique popliteal ligament. And here, not seen very nicely, will be your anterior or Humphreys part. So where you'll be seeing the long axis of your posterior longitudinal ligament, you'll be seeing the cross section of the meniscofemoral ligament. Meniscofemoral ligament will be from the meniscus, lateral meniscus to the medial condyle. Okay, everybody try to understand. This was your cross section of the meniscofemoral ligament one. Another is here, and this is your PCL. Everybody understood it?
Yes, sir.
So if I'm holding the probe like this, so first, what I was doing, I was over the medial condyle and little bit of tibia is seen. This is your little bit of tibia. Little bit of tibia. This is your medial condyle. This is your condylar, medial condyle and cartilage. So now I'm sliding it, coming laterally. When I'm coming laterally, so now stop here. So here, what you are seeing? Here, this is the condyle. This is the intercondylar area bone. This is your PCL. And this is one of the cross section. This is your bright white is your oblique popliteal ligament. And here, this is your one section of this, the meniscofemoral ligament. So meniscofemoral ligament, I have to see, if I want to see the long axis, then I have to hold the probe like this. Now I'll be showing you the meniscofemoral ligament in the long axis. So if I'm coming here, so you can see this was your lateral meniscus, lateral condyle, this is your medial condyle. And this you can see the popliteal artery. So now I'm coming down. Only this part I'm coming down. See, lateral part I'm fixing over the medial condyle. And I'm just tilting the probe like this. So now I'm in the meniscus, lateral meniscus. And in this position, okay. So try to understand.
these three hyperechoic areas. One is your this one, oblique popliteal ligament. After that one ligament, this is your the posterior part of the meniscofemoral ligament, or which is known as Reisbach's ligament. And this part is your the anterior part of the meniscofemoral ligament or Humphreys ligament. And now the PCL is looking hypoechoic now. If I'm tilting it, it will be showing hyperechoic. So now the PCL is seen as a cross section. If I'm holding the probe like this, I'll be seeing a long axis. If I'm holding the probe like this, I'll be seeing the short axis. Okay, is it clear?
Yes, sir.
Okay, I'm showing you again. So what I was doing here, I'm looking for the two condyle. Okay, now I'm seeing the two condyle. This is your lateral, this is your medial. So what is the meniscofemoral ligament origin? From lateral meniscus to the medial, the condyle. So now at this position, I'm going down. I'm going down. And now I'm fixing the medial side of the probe, medial side of the knee. And now I am tilting it like this. So now I'm losing the bone. And now I'm in the meniscus. So what I can see here is the meniscus. And now here I can see the long axis of these two ligaments, the two portions of the ligaments. Now I can see very nicely, and all are hypoechoic now. So I'm drawing it, and then again I'll be removing the drawing. So the most superficial one is the oblique popliteal ligament. After that, this area, this ligament is the posterior part. That means this part of the meniscofemoral ligament. This part, two band is seen. This part is your anterior part of the meniscofemoral ligament, and this is your PCL. Now it is because I have tilted the probe, I can see it is hyperechoic. Depending on whether you are tilting, whether you will be seeing sometimes hyper, sometimes hypo. I'm reviewing the drawing and again try to understand. Can everybody understand? So nice picture now. So again, three longitudinal layer you can see. One is this one, that is your oblique popliteal ligament. Then second layer, then is a cross section of the posterior cruciate ligament, and this is your little bit of sagging, that is your anterior. And here is your ACL. Here is your ACL. Again, cross section. Everybody can appreciate or not?
Yes, sir.
Okay. So now arcuate ligament. Arcuate ligament is from here. I have to palpate the fibular head. I'm palpating the fibular head. Let me reduce the depth now. And let me change the probe. Because it is superficial, I'll be able to see it better if I'm taking the high frequency. Okay, so this is your fibular head. I'm holding the probe here. So this is the fibular head. And this ligament is your arcuate ligament. This is your lateral band. The whole thick, very thick. And now, if I'm tilting the proximal end of the probe, what is this? This is your condyle. This is your lateral condyle. This is your tibia. This is your fibular head. And this thick ligament is this thick ligament. This part is little bit of hypoechoic, not seen nicely. If I'm tilting it, it will be seen. So this whole area is your arcuate ligament. And now above that, the biceps femoris. These are biceps femoris tendon, short head and long head. Now what I'm doing, I'm keeping everybody understood the arcuate ligament part? Not the top part. Top part is this is your long head and the short head of the biceps femoris getting attached there. The two head you can see very nicely, 1 and 2. After that, this is the arcuate ligament. This thick, very thick. And now what I'm doing, I'm tilting the proximal part of the probe, distal part of the probe over the fibular head I'm fixing. I'm tilting it. Then I'll be seeing another part of the arcuate ligament, which is getting attached to the meniscus. So here the arcuate ligament, the lateral head, they are getting attached to the meniscus. This one. So this is another wing of the arcuate ligament. So this is one, this was one, and this was another.
Okay. So up to this. So a lot of things are there in the knee. Still a lot more things are there, but this is also quite advanced. So I hope everybody appreciate it, and you can see the videos again and again. So I'll be leaving soon. I have to catch the flight. So Milton is ready.
Yes, sir.
Okay. So I have to make you co-host, and I'm making host series. I'm
Yes,
making
sir.
because I have to leave.
Yes, sir. Sir, I have a safe flight, sir. I have a nice time.
Okay.
Sir, have
And
a safe flight.
if anybody have any more questions, and if anybody, because I am having, running short of time, I thought I'll be completing by 7:30, but it is already 7:45. So I cannot wait little more. But what I can promise you, if any one of you, please go through the videos what I have shown you. I told you knee is my very favorite area. After the lumbar spine, my next favorite area is your knee. So, and lot of things are there in the knee. If you want to see anything again, I'll be demonstrating on the next Thursday. Okay, when I'll be demonstrating the ankle, that time I can demonstrate. Fine?
Yes, sir.
So, Siris, you are now host. And
Yes, sir.
Milton, you can go ahead with the presentation. So, thank you very much, all of you, and good night.
Good night, sir. Milton, are you sharing the power?
Yes, I'm sharing my slide. My slide is visible or not?
Yes, it's clearly visual, Milton.
Okay.
Can you make it a full?
Sure.
This one?
Okay.
Okay,
Is it okay?
Yes, yes.
Okay. Thank you. After a very nice demonstration, we have started our second lecture regarding our knee pathology. So actually, a lot of pathology in our knee, but most common pathology is the osteoarthritis knee. But other than osteoarthritis knee, there are a lot of things you should remind your mind, at least when you have to examine and when you have to actually exclude what other things in behind of these. You should actually remind all these things, otherwise you sometimes make some mistakes. And another one things, only the osteoarthritis knee is not the common. There are sometimes some coexisting part also, including of these osteoarthritis also, like if there is some bursitis, some tendinopathy, tendinosis. So not only take care of the only one things like the osteoarthritis. If it is just clear cut evidence of the osteoarthritis knee, but you have to also exclude the other things also. Okay, so now the first topics, that is most common topics, that is our osteoarthritis knee. So actually in case of the osteoarthritis knee, the joint disease may actually decrease or actually erosion of the bony hyaline cartilage. And this cartilage actually either by due to the degeneration process or by the some disease, like if there is any inflammatory condition like the spondyloarthropathy or any reactive arthritis or any kind of inflammation inside the joint, including the gout arthritis also, they actually causes the microinflammation and microtrauma that leads to the erosion or degeneration or decrease of the joint cartilage, number one. And number two, there is actually, if there is no non-inflammatory part, but there is the aging part also, so it also causes the erosion of this layer also. And there is another things that is called the in the joint that is covered by the synovium. If there is any inflammation in the synovium, this also causes the actually continuous inflammation is occurring. So it causes the also the decrease or degeneration or inflammatory change of the hyaline cartilage. So all these things actually lead to the either degenerative or either the inflammatory changes of the joint cartilage. So if we are looking for the global ratio of the osteoarthritis, especially, so it is almost the third common condition in the world. So after low back pain, after that the shoulder pain, it is the most common. There's the third one of the global issues. And in 2010, there are 250 million people are affected in the osteoarthritis knee. So it's almost the 3.6% population over the world. And the prevalence of the osteoarthritis knee is gradually increases. So more than 60 years, in case of the male, it is 17%, but in case of the female, it is more than 29.6%, because due to a lot of causes like the weight, there is the some systemic causes like the diabetes mellitus, or if there is the any in case, especially in case of the female, there is the changes of the hormones. So each and everything is just actually accelerated the decrease or degeneration of the hyaline cartilage. So like the age, gender trauma, or metabolic any disease, if there is any metabolic symptoms, so it may leads to the actually erosion of the bony surface, and the bone, if there is bone mass, obesity, genetics, and the mechanical factor also. So actually a lot of causes there. Sometimes sometimes even in the, it's causes the genetical also. So if there is no any important part like there is no mechanical, there is no others factors, so also you consider the genetic part also. So the total pathological changes involving in the joint, like the focal narrowing of the hyaline cartilage, number one. Then actually these decrease of the hyaline cartilage, actually bone, there is some bone remodeling. That's mean they changes, they want to actually making how to actually makes it the normal. So some there is new bone formation, so it's called like the osteophytes. It's sometimes there is it's actually start with the some sclerosis. So after that it causes the bone remodeling, at least the grade 3 or 4, it causes the osteophyte, and there is a lot of bony spouch is outgrowing from the surface of the joint. So there is the one another thing very important, that is subchondral bone volume is increasing, and the marginal new bone formation like the osteoporosis, like the osteophytes. And if when the actually joint space is narrowing, so that causes the ligament changes, and also the in between two joints there is the very important part, there is the meniscus, so it causes the bulge out from the line. So these all mechanism actually happened inside when actually degenerative changes inside the joint. So now how can we diagnose it? Actually, first one, the history. So usually this patient, if there is the degeneration, so usually pain in the morning less than 30 minutes, and when the actually climbing, stairing, or getting up of this chair, or sometime when using the low commode, after that he went to get out from the low sitting to the standing position, that time actually loaded the knee joint, and this load cannot actually bear by this joint, because already the hyaline cartilage is affected, and these broken or the thin hyaline cartilage and the total bone actually cannot bear this weight. So actually movement, up steering, down steering, this actually movement actually causes the pain. And sometimes if there is the more further advance, so sometimes there is the instability also. So if we are see the joints, if there is not advance in terms of not advance in osteoarthritic changes, so there is no deformity like the varus or valgus deformity is not there. Usually the varus deformity is seen in case of the advanced osteoarthritis. If not like the advanced type of the joint remodeling, so we can find out the crackle sound inside the joint, and that is actually the flexion and extension. Usually some patient more pain in the flexion and some patient in the extension. If pain in the extension purpose, so that time actually the anterior part of the hyaline cartilage is not bearable to this pain. If there is the when it is in the flexion type of the pain, so that time you consider if there is some correlate with the posterior part of the either medial or lateral meniscus, because sometimes there is the cracking inside or the rounded side of the meniscus. So that causes the actually when the flexion of the knee movement that causes the increase of the pain. So sometimes the joint may lock, and sometimes swelling and the fatiguing and different of the daily works, difficult to maintain the daily works. So now the examination, how we examined is there is any swelling or not. If see something, if there is starting of swelling gradually, that's mean pain for the last 6 months and swelling gradually increase, so it's most probably in favor of the degenerative changes. If the swelling is sudden onset, like I have no swelling for the last 6 months, but suddenly for 2 days it is huge swelling, and the joint is very big difference between them. That's been the grade either 2+ or 3+ swelling inside the joint, in the joint. So it may correspond to the inflammatory or any inflammatory provoked with the degenerative changes or not. So if there is any crepitation or resting range of movement should be elicited, and the tenderness over the joint line, either medial side or the lateral side, because always consider there is some changes around the joint. So if there is the medial side around the joint is changes, so medial meniscus or medial collateral ligament also find out if there is any problem or not. So the mild inflammation, warm, you should just compare with the other side of the body or other joint also, if there is any temperature or not. Weakness and wasting of the money also, muscles also consider, because it is a lot of a lot of actually innervation getting this joint, because there is the genicular nerve and there is the others muscle synapses. So if there is any like any motor deficit or like this, if there is a L5 L4 5 or L3 L4 nerve root problem, there is the it also mimic with the knee pain also. So you have to exclude if there is any radiculopathy or not. If there is any radiculopathy and it mimics the knee pain, so not considered that it is the knee pain. So always if there is any pain in anywhere, always consider the proximal and distal joint examination and exclude the wall things if there is any nerve, especially if there is the muscle wasting. So always consider there is the main major motor supply is hampered or not. So in case of the advanced osteoarthritis, so meniscal tear is near universal. That's been almost all patient. There's some sort of the meniscal tear you may, and sometimes the meniscus actually just pop out from this area. So it's that compress when it is just pop out. So it compress the medial or lateral collateral ligament. So meniscal tear actually not associated with the wall osteoarthritis, but it may associate with these things. And then the another one thing is that the anterior cruciate ligament, the common or diagnosis, and sometimes the repairing the meniscal tear way unlikely to improve the disease condition, and sometimes the repairing and regeneration by if the advanced osteoarthritis, so we cannot actually all together we cannot regenerate these things, but many of the time we can regenerate with the PRP. If not, it is not improved with the advanced osteoarthritis, then we consider either a lot of treatment like the radio frequency or even the cryo, or they say we can go for these things. So in case of the lab investigation, usually the we do all routine investigation, including because we have to exclude if there is any inflammation or not, there is any synovitis or not. So better to, if there is any collection, should be always consider synovial fluid examination. If there is the WBC count is so high, if there is any pus cell or not, so you should actually exclude these things. And another very important things, that is you should actually lab examination like the CBC, CRP, serum uric acid level, sometimes like if you are considering there's the inflammatory part, so you can do the sometimes the rheumatoid part of the rheumatoid arthritis or part of the spondyloarthropathy. So it always you have to search these things, either the primary cause of the osteoarthritis or the secondary cause of the osteoarthritis or not. So so diagnosis by X-ray is very important part. You can classify either it is type 1, 2, 3 or 4, or like the advanced osteoarthritis or not. And also consider by the ultrasound, because when you put your ultrasound, you can find out not the bony changes or bony changes, not only the bony changes, but also there is the some other changes, like there is the any ligament changes or meniscus changes, or there is the tendinopathy or tendinosis, or there is the bursitis or not, or there is the collection or not. So either this collection is the inflammatory or the non-inflammatory. So a lot of a lot of clue that actually gave by the USG when you have actually suspected this kind of problem. So also, there is the, in case of the knee pain, there is the ACR criteria like the 1981. There is the give the criteria like the more than 50 years and morning stiffness less than 30, crepitus, bony tenderness, bony enlargement or not, and there is no palpable warmness. So these criteria is on favor actually favor goes to the degenerative changes, not for the inflammatory changes. So in case of the mild, or there is if there is any doubtful change, so that is only the 10% hyaline cartilage losses. So it is not the so much actually you cannot so much changes in the normal to the type 1. So it is so it's called as the doubtful osteoarthritis type 1. So after that, the type 2, there is the joint space, some narrowing of the joint space. Number 2, the cartilage to bring the breakdown and occurring the osteophyte. And after that, the grade 3 or moderate, the moderate joint space is the reducing gap in the cartilage and can actually you can changes the right and left side changes, and there is the some that's mean there is the change in the sclerosis changes, and some there is the vacuum sign you can see in the X-ray. And in case of the type 4, there is the more than 60%, there's been more than 50% or more than 60%, and sometimes there is the changes of the angle of the total knee alignment. So there is change of the Q angle, so it's more than 30°. And there is one important part, there is the huge crepitation and sometimes the bony outgrowth. That's mean the osteophyte and others is seen a large osteophyte you can see, and there is the mark actually changes of the hyaline cartilage. Okay, so it is the osteoarthritis grade 4. So you can see a lot of changes in the narrowing of the joint, and there's a lot of osteophytes. You can see a lot of osteophytes here and here, and you can show also other things. There's the some hypo area you also see in this X-ray also. So there is a lot of differentiation. You can see there is either there is the chronic inflammatory arthritis like the rheumatoid arthritis, part of the rheumatoid arthritis or not. If there is the pseudo or the gout, or sometimes the part of the hip arthritis, and sometimes the you can consider the others disease like the medial side. So it's maybe either the patient serum, sometimes the iliotibial band symptoms if there is the pain in the most laterally, so meniscus tear also. So you have to actually exclude all of these things. And very important part, that is the in case of the management or treatment, like there is the education about the osteoarthritis before. It's the part, very important part of the management. And also the sometimes when actually if there is the solely degenerative, so sometimes when the functionally improve, that's mean if a patient have the very active or very more working in one day, so that times patient sometimes feel the more pain. But important part, you should also active, not short for the always in the resting condition, because this active part may actually propagate actually decrease the disease condition or disease progression also. So like the if you have a knee pain, you not work, you not walking, you do not doing anything, it's totally harmful for this patient. You need to the quadriceps and other muscles, hamstring muscles, as with other muscles, you should actually improve the muscle strengthening, and muscle should be in favorable of the weight bearing condition. Because if there is the improve of the muscle condition and muscle is not degenerated, and very one things, every joint have the biomechanics. There is osteoarthritic change, so that times actually biomechanics is changes. So these muscles actually make to come down to the previously biomechanical status of this joint. So always consider is important, very important part, that is the exercise. So other like the treatment part, the exercise, the resistance exercise, the aerobic exercise, the and the very important part, sometimes we also give like you should walk in the water, in the swimming pool, because when you are walking in the water, it's just floating your body, so not much more weight in your knee. So also a lot of exercise you can do in the sitting position and in the lying position. So lot of treatment option like the NSAIDs, but in case of the advanced age, so always consider there is the very minimum dose and very minimum duration of the uh, actually NSAIDs. And sometimes we previously we give the glucosamine and condensate, but recent data is not on favor of this. So you can give these things only the supplementary, otherwise there is no effect on this condition. So better to actually avoid these things. But many of our friends actually use this chondroitin and glucosamine, but it's not so much good in the good practice. And also the evidence-based medicine is not so recommended these drugs currently. So very importantly, we have used the duloxetine because it is already FDA approved, and you should start it as low as doses. Better to start with the 10 milligram, then 20, then 40, then 60, then 120. Only one important part, that is the side effect, which is the nausea, drowsiness, dry mouth, headache, and insomnia, and some sexual dysfunction. But duloxetine is the very good drugs, because I have used these things for last 7 years. A excellent improvement of the osteoarthritis. If there is the coexisting other disease, you have to treat these things. Otherwise, the solely degenerative changes of the osteoarthritis knee, it is a very good drugs. And nowadays FDA is approved these things, and you can give without any doubt. Just keep in mind the side effect. So then the prolotherapy, like the dextrose, you can give there is the any a lot of ligament is involved around the knee joint. So if you need to help also strengthening of the ligament of around the joint, so you can use the dextrose, and you can also the platelet plasma inside the joint, because it helps to regeneration of the new hyaline cartilage. And you can also the stem cell therapy, someone many of our actually use these things. And also you can use the 50% dextrose with the local anesthesia and ozone. You can for the advanced osteoarthritis like the grade 3 or 4, if there is a multiple time repeated collection, so you can use better to dextrose with the ozone. It gives the very good recovery. And also in case of the advanced osteoarthritis, you can either genicular nerve block by the alcohol phenol, or by the radio frequency, or by the cryo analgesia. So these are the very newer, not newer, these are the advanced treatment. So we are considered for the advanced type of problem. But think if there is the deformity, so valgus deformity, first option is the surgery. If patient is not fit for the surgery, like patient have the many coexisting disease, so not fit for the surgery, so that time actually consider, or second opinion should be the genicular nerve block, because it gives only next 2 to 3 years pain relief. But if you are in the grade 4 and there is the bony deformity and bony angle changes, so that better to planning for the surgery by the orthopedician, because this replacement gives more than 10 to 15 years for helping the pain-free life. But many of the time, after the replacement of the knee surgery, also need the genicular nerve block, because what I say, that only the bony outgrowth and the osteoarthritic changes is not the pain generators. There is some other pain generator. So it may sometimes there is the other pain generator that actually causes the pain after replacement of the knee. So okay, so when actually we have a planning for the radio frequency, when there's the wall conventional treatment like the oral medication, if the PRP wall are failed, and if the patient is not in surgery, patient cannot do for surgery, so then you can plan for the genicular nerve block in the superior medial, superior lateral, and the inferior medial. So these 3 branches usually are do, but another 7 site we can do for the radio frequency in one settings. Okay, at least we have to do the diagnostic block more than 50%. Near the 50 to 70%, you should consider the pain relief after doing the diagnostic block. After that, you can plan for the genicular nerve ablation. Okay, so surgery, it's actually not our main part, but if needed, so you can plan for the surgery and send him to this orthopedic surgeon. So if then the second condition, that is the effusion. So thing actually what we sometimes what we or our colleagues do, if there is any effusion, just aspirate and give some steroid or something like this. But think only the aspiration and give some either steroid or even not steroid. Many of the patient came in my OPD, just I taken aspiration from my knee for last 3 to 5 years for every 3 months. But it is not actually the good scenario. It is not the good treatment, because why actually the repeated swelling, either it is the first swelling or either is the repeated swelling. If it is the first swelling, so you should also consider either the onset of action either is very short time or the long time. If there is very short time, always consider if there is any inflammation or not. And very important part, if there is any inflammation, so you can see under the ultrasound the droplet, there is the color, a lot of color actually taken by the covering, there is the synovium, because if there is inflammation, so synovium inflammation is also the part of the inflammatory total joint inflammation. So it takes the color. So thickening of the inflammation, thickening of the synovial also you can see under the ultrasound. So the This is the joint effusion. So there is the suprapatellar joint effusion. There is a small amount of fluid is like here, but it is a suprapatellar collection. We can see, and this is the actually the prepatellar bursitis, and you very gently actually you should see this because it is most superficial. If there is any trauma or injury, we can find out because it is just over the patella, so you can see very easily under the ultrasound. So another is very important part in case of when actually we scanning the ultrasound, that is the patellar fracture, because it is the overshadowing by the posterior part with the anterior surface, posterior surface with the anterior surface. So many of the time we cannot see this small break under the X-ray. So this is the very common view, common scenario in case of the ultrasound, because when actually do only the X-ray, you can see there is nothing in the X-ray. But when actually do ultrasound, you can just find out if there is any crack over the bony surface. So it's maybe the due to the bony crack, due to the bony fracture, either history of the fall down in the ground or not. So it is also the jumper's knee. This is the this tendon actually the degenerative changes. So this is the this thickening is there is the very good thickening, so you can the fibrillar pattern, but here is the losses of the fibrillar pattern, and the thickness also the increase. If there is a thickening and the loss of the fibrillations, so this is the sign of the tendinosis. Okay. So here we can see the patellar tendinosis very clearly here. It is the normal part, but here's the diffuse bulging of the patellar tendon. Here we can see the infrapatellar bursa. Okay, here we can see the collection, small collection, just beneath the just under the patellar tendon. So here also we can see the infrapatellar bursa. Now, the medial knee pathology. Medial knee pathology, usually in the medial side there is the some important structure. We can see there is the one condyle. This is from the femur, and this is from the tibia. So there is the space, joint space. So another very important, this is not the just regular, this is the irregular margin. So this is the irregular margin, and there is the medial meniscus. There's a two part, this is superficial part and the deep part. Deep part is just attested with the very closer to the medial meniscus. So the superficial part and part of the deep part, this is actually bulge, and this is the hypoequic in contrast of the lower pole. So this area actually is not actually healthy, as well as it's not the taking care of your body weight. So if there is any irregular changes of the body, so there is some things you should keep in mind. Number one, there is the inside the tendon there is the microtrauma one node. If there is the bony changes like these things, so it's maybe happened with the osteoarthritis. And if there is there is sometimes the changes of the medial meniscus, and it is the chronic in like it's for the last 6 months or last 1 year. So it's for the long term, so it's not the very short history. So if there is this like of changes, so you should consider always it is the long term changes. That means it is the chronic changes. So this chronic changes, so you should consider the chronic pathology. Okay, if there is the patient history of the I am fall in the ground and my leg like the varus like position, after that there is the middle side of the knee pain. So actually there is the small fragment of the medial meniscus, or a small fiber of the medial meniscus is like the tear. After that there is the chronicity of the pain, so it causes the irregularity of the bony mark, and also the increase the actually thickening of the medial meniscus. So you should consider these things. So medial injury like these things, you can consider these things. And medial meniscus we can actually do two types of examination, like the Laplace grind test and the McMurray test. You can see from our the YouTube channel. There is actually how to actually examine these things. So this is the applied grinding test. So we can actually consider either there is the meniscal part is affected or not. So this is the McMurray test. We can just in and outside we can and just knee is in flexion position, then gradually extension, and we can consider either there is the meniscus pain or not. And there is the meniscus pathology, some other meniscus. There is the, you can see the vertical, see hypoechic area. This is the vertical meniscus tear. If there is any cyst, just I got a one patient has the meniscal cyst pain for last more than 5 years. They actually did a lot of investigation like the CBC, X-ray and other pathology, but pain never ever gone from the knee. But actually when actually we put our ultrasound in the knee, we can find out there is the collection just in the medial meniscus, just correlate or just continuation of the medial meniscus after aspiration from this cyst. But after a few days, patient just fully pain free, and after that 3 to 6 months later, we also saw this patient that still now patient is fully pain free. So what actually happened inside or outside or around the knee or any pathology, it's the actually our motto, and we have to actually find out this pathology. See, there's the big large osteophyte you can see. So what's happened? The meniscus and the joint space is very narrow. So meniscus goes to the uplift and push, and the medial collateral ligament just uplift. So the all dynamics, just so the all things actually when push and the popped up of the meniscus, the total mechanism is changed. So it causes the continuous irritation because there is the big osteophyte, and it causes the pain when actually movement, and there is the pain also. Okay. So the cruciate ligament. So actually cruciate ligament is the sometimes is the pain is the severe pain and instability continuing the rapid if there is the injury, so it is the rapid swelling. If there is a history of any injury and within 1 to 2 hours there is a huge collection, so let's consider if there is any crucial injury or not. So it also decreases the range of movement, and sometimes patient tell us my joint is sometimes the moving from the upper part, and I am not just walking, I need to just sit that time. After that I need to reposition my leg, and after I can actually move these things, and I cannot run. I should always conscious during my step over the either the shiri or when I actually run. Okay, so cruciate ligament, we have to actually, there is the two type of the examination, like the anterior droid test, posterior droid test, or the Lackman test. We can see if there is the sagging or if there is the lagging. So that times we can consider there is the either so we can see this, there is the sagging. So this is due to the because here actually connect of the ACL is like there and PCL is like there. Okay, so this tibial sagging is due to the posterior cruciate ligament. So due to the posterior cruciate ligament, and the posterior droid test also, if the positive, that is also considered the PCL tear. Now the collateral ligament. So collateral ligament is actually stressing either by the varus or valgus stress. So there is two type of collateral ligament. So one is the medial collateral ligament, then another is the lateral collateral ligament. So medial collateral ligament is stressing with the valgus stress test, and the lateral collateral ligament actually we are stressing with the varus stressing, by the varus stressing. So we have to actually this is the actually when but we stressing to the opposite side. So that time actually if provocate or same time or the more pain when actually stressing these things, so you should consider either there is any collateral ligament, either there is some fiber tear, or there is some degeneration, or there is some like um, mm, like tear or not. And there is a lot of bursa around the knee joint, but very important medial and just posterior medial side of the tibial tuberosity, that is they call the pes enseran bursa. So it is very important bursa, because many of the time actually we not so much careful about the all kind of the bursa, but this bursa is many of the time actually causes the pain in the medial knee pain. Also always consider or always exclude the pes enseran bursitis inflammation or not. So here we can see this is the area for pes enseran, because pes enseran bursa and the medial collateral ligament. So the common origin of the pes enseran common origin of the three tendons, that is the common insertion, that is the actually three tendons. Either you can remember by the GTS or SGT. So SGT means the sartorius. Number one is the sartorius, and the above one is the sartorius. After that there is the gracilis, and after that there is the semi tendinosus. So these three tendons together inserted here, and the bony plateau, there is the another very important like the fibrous tendon, fibrous ligament is inserted here, that is the patellofemoral of the like the actually oblique fiber of the tibial collateral ligament, or that's mean the medial collateral ligament. There is the two fiber, there is the one fiber, that is the oblique fiber. So this oblique fiber, and between these three muscles, so in between there is the small collection, there is the inflam like this. You can see this, there is the inflammation in between this tendon and this ligament. So this actually causes the pain. So it's called like the pes enseran bursitis. Okay. So medial knee pathology consider lateral knee pathology is for the either the tibia iliotibial symptoms. So this band is just come from the upper side from the hip. So it is very tough structure actually, where actually inserted in the tibia. So this compact structure, when actually friction, if there is any multiple trauma or the repeated actually using, so that time actually small collection there. So it's maybe due to the iliotibial band symptoms. Now the lateral collateral ligament, either there is some sprain changes or there is the cyst. You can see here the small collection and also the diffuse bulging of the lateral meniscus in the knee side. Okay. In the posterior side, we can see the commonly the Becker cyst in between the medial head of the gastrocnemius and the semimembranosus. So we can see the comma shape origin. It is actually the continuation of the anterior the joint. So it is the actually continuation of the joint. So many of the time actually we are just find out the posterior part effusion or sometimes the bulging. So it may be due to the Becker cyst. Okay. So we can see there is the cystic Becker cyst. We can find out these things. Okay. Now, is there any other? There is many other condition like the gout, because it also gout is the monosodium uric crystal deposition in the synovium. So and it's not as very few patients. So in our practice around we got a lot of patients with the knee pain also. So there is sometimes the gout, so we need to some consider the actually reserve, or actually consider you should some food, and you should also excrete the uric acid from your body regularly. So it's the prevalence in case of the male is more, it's the 5:1, and approximately 1 to 2% population we can see these things. Okay, and uh, if patient have taken like the meat, if there is the seeds, so a lot of foods if there is have taken, so actually that increasing the monosodium urate crystal and also inflame these things. And actually first times we are considering the hyperuricemia. After that, if it is the continuous in manner, if the always you are just cattle or regular medication, if there is increasing of the uric acid, so that time you consider the at least gout. So at least 2 or 3 times you should consider the hyperuricemia. After that you can consider as the disease of the gout. Okay, so it's also risk factor. There is some risk factor, rise the hypertension or vascular changes, renal disease, or the even there is the cardiac elevation or not. So so the a lot of actually medication, like if there is no history of the gout, but when actually there is the some drugs like the thiazide or loop diuretics or low dose aspirin or pyrazinamide, so these causes actually increase the gout. So it should be also considered if patient is in the thiazide for the hypertension, so it may causes the increase of the uric acid. So it considered that you should stop the thiazide, and you can many of the time the patients comes to normal of the hyperuricemia. So another red meat and the seafood, so you should consider this type of the problem and this type of the foods also. And also the high fructose type of the high fructose intake, so it causes also the increase of the hyperuricemia. So it's the common scenario in the commonly find out in the grade 2 of the foot, but not always consider the it is the main issues, because more than 50% patient we can just started with the swelling redness of the grade 2, but it's not always. So if there is any knee pain, always consider that if there is any either uric acid is more or not. Okay, so actually there is any other clinical feature, but I'm not so much interested to go for these things. But very important these things, that is the treatment option. So treatment, initially treatment is the oral colchicine if there is not any like contraindication. So we can start with the 0.5 milligram or 0.6 milligram for 2 to 3 days for 3 days. Okay, after that we can use or start it for the allopurinol or so actually this allopurinol actually decrease of the total loading of the uric acid, and it actually excrete from the body, and also the phenofibrate also. So these three drugs actually we have used these things. So oral colchicine for the initial part, and you can consider also the NSAIDs, and the continuous part you can start with the either allopurinol or either the phenofibrate. Okay, sorry, Febustate. So we can also use the Febustate. So it's recommended starting dose with the 80. After that, if the uric acid concentration is gradually down and the clinically it is proved, then you can go down for the 40 milligram daily. So there is some changes of the popliteal tendon due to the gout changes. So it's not always like this. You can find out in the ultrasound, but you can just see these things. Okay, Now is very common is the jumper's knee, because many of the time actually in our patella is very prone to injury, because it is most superficial, just under the skin, very thin layer of the soft tissue. So when actually people are playing, and sometimes when people actually affect with the hard surface like the floor, and sometimes there is the our housemate or worker actually working with lay down and pressure, by the helping of the pressure over the knee joint, actually that actually causes the these patellar tendon changes. So it's also the direct, sometimes may also direct trauma over the either quadriceps or patellar tendon. So so it's usually there is a history of either repeated trauma, or there is the huge trauma during either the road traffic accident or any other kind of the sports injury also. So then the another things that is called the runner's disease. Actually this runner's disease actually friction of the tibial band with the lateral knee, especially the tibial band with the lateral femoral condyle. So here the lateral femoral condyle is bulge, and this is the tibial iliotibial band. So when actually the friction, so this is causes actually the symptoms of the iliotibial band symptoms or runner symptom. Usually people who are in the marathon race, so what's in the marathon race is not the so firstly it is the gently but for the prolonged time. So many of the time actually this causes the repeated friction. So it causes the, because it is a dense tissue, so if there is the multiple friction with underlying bones, so it causes the actually there is the changes of the tendon, so it causes, so it called as the runner symptoms. So there is the one very important, this is the Osgood-Schlager's disease. In my initial practice, when I have started in 2016, that times actually one very young boy come with the knee pain, especially in the tibial tuberosity area pain, and I gave him in the one X-ray. Just I saw that I can probably mention it's age around either 14 or 13. It's around these things. So there is the broken, like there is a broken of the tubal tuberosity. So I am not actually understand that times, because that times I am not so much used to this kind of diagnosis. So either there is the fracture or not. So I got the history. Patient have the repeated history of the trauma or fall in the ground, because actually when he went to for the play, many of the time he fall down in the ground in the field. So repeated trauma and repeated actually injury, and it causes this type of the problem. So actually it is in the young patients less than 18 years of old, so it causes this type of the problem. So when, because we know that the patellar tendon actually inserted in the tibial tuberosity. So when actually patellar tendon actually hugely pulled up these bony areas, so sometimes the bony growth or bony outer cortex is actually just sitting down from the normal stage to the upside. So it's look like this type of the so breaking of these things. So but never actually scared these things. You should consider few of these things, avoid the heavy vigorous exercise or the sports, or also mention that not try to fall in the ground and ice pack. And if the patient is maintain this regulation, so actually gradually when actually after 18 years, so it gradually actually come down and it's gradually normal. So on very important, sometimes there is the changes of the tendon. So either there is changes of the tendon or not, you should consider by the ultrasounds. Okay, so we can see that there is the changes. Okay, so there is the thickening and there is the bony outer cortex is just changes from baseline to the upside. So it's actually when the repeated trauma and the pull of the patellar tendon, just the cortical um, actually pull out from the normal surface. Okay, and also consider there is sometimes there is the collection or not, because it is a repeated injury, so there is some bursitis may uh, find during the ultrasonography. So if it not improve with the NSAIDs, avoiding of the physical exercise and avoid of the repeated fall in the ground, and if not improve that, after that you consider for the injection, but better to wait and see, because many of the time it quietly normal after giving this advice. Okay, so now the tibia fibular pain symptoms, it is the very important, because there is the below the knee joint, and there is the small part of the fibula is attached with the tibia. So it is the head of the fibula attached with the tibia. So there is the one very small joint. But if there is the direct trauma, if sometimes in the sometimes we have sit like the lateral position, so it may causes the repeated injury or trauma, so it causes sometimes the arteries also, and there is the very small joint. So also many of the time the rheumatoid arthritis may be the part of the total whole rheumatoid changes. So if there is I got I got a patient few months back. There is the very severe pain, and he was a Muslim. He cannot actually pray in sitting position. So actually, when palpate and when ultrasound, there is the outgrow bronch, and there is the significant changes of the joint space in contrast with the other sides, with the normal side. So this is actually the changes. So this is the tibia and this is the fibula. So here is attested with this part. So if there is the inflammatory part, you can consider the steroid injection. If there is the non-inflammatory, it is the post-traumatic or the degenerative changes, you can consider the PRP in this area. So another very important part, that is the semi-membranosus insertion symptoms. It is very important, because if there is the posterior area pain, and especially in the medial side, many of the patient you can just you can got like with the semi-membranosus insertion symptoms, like there is the one important bursa lies just under the semi-membranosus, and it is many of the time affected if there is a coexisting the osteoarthritis. Many of the time it affected this type of the problem. So always consider and always do the ultrasound of the semi-membranosus insertion area and consider if there is the pain or not. So many of the actually athletes or the player may actually happen these things, but its insertion is like this thing. So if there is any posterior especially the posterior medial part is painful, so that time consider either there is the same membranosus bursa or same membranosus tendon is affected or not, or there is also part of the medial head of the gastrocnemius and the medial collateral ligament and the medial condyle also. So it's maybe actually affected by if patient with the present with the medial collateral medial posterior medial type of the pain. And there is the unimportant that is important, and I am very closer to the conclusion. So this is the hamstring tendon. So hamstring tendon is the one part is comes from the lateral side, that is the lateral side and also the medial side. So so the medial side there is the three tendon two tendon, and then on the medial side there is the biceps femoris. So all are together, and if they're considering the pain is in the medial side, it may be either the common hamstring tendon. So if there is changes, and this pain sometimes in the just ischial tuberosity also, so it's sometimes referred from the ischial tuberosity to the knee. So either pain is in the insertion area or either in the origin area like the tibial tuberosity also. So you have to consider hamstring muscles together make confined with the pain also. Okay. Another one important part, that is the perineal nerve, because the perineal compartment is the lateral side, lateral part of the legs, and this perineal common perineal nerve is actually come from the posterior side, and it turns in the lateral side, and it's divided into two part. One is the superficial and is the deep. So this part, when it is just crossing the bones, it is very closer and so much closer with the head of the fibula. So it may be either if there is any direct trauma, so it causes the actually injury to the nerve, or many of the time the repeated injury or repeated actually injury, so it causes the nerve pathology, like there is the burning, numbness, shooting plaque of the pain. So it many of the time actually patient give this pain with the tingling, numbness, and some sort of the very mild of the weakness, or this kind of the problem. So it may be either the entrapment of the perineal nerve. So you should consider, and you should also tracking the nerve from the posterior side, from the sciatic, then the tibial, common perineal, and common perineal up to the dividation. So if there is any swelling, if there is any nerve pathology change, nerve morphology changes, so it may be due to the perineal entrapment. So MSK is very important part, and also very important part is like you should consider a lot of disease when actually examine, and actually considering the evaluation of the pain. Either it is the common pathology like the osteoarthritis, or sometimes the extending other things. So first one is the history, is very important part, that is the um, examination evaluation part. After that, you should consider the investigation, including the ultrasonography of the knee. After that, you should planning for management of the patient with the medication, or further, either if patient needed the intervention like the PRP, dextrose, or steroid, or ozone, or radiofrequency, either it needed or not. So the whole patient or the whole knee pain is not considered only the osteoarthritis knee. So it is the part of the knee pain, but all patients are not considering the osteoarthritis knee, because a lot of considering pathology we can see in our class. Okay, so thank you for patient sharing. If there is any question, please ask me. Hello, Shirish.
Hello, Milton. Thank you for the wonderful, elaborate class. I'm sure it is a very big topic, and thank you for explaining everything within 1 hour. Any of the participants has any questions, or would you like to focus on any pathology to be repeated? Hello, are you guys there? Milton, I think. Can you hear me, Milton?
Yes.
Okay, I think none of them have any questions. Thank you, Milton. It was a very wonderful, deep, elaborate class. I'm sure students may have because of the big topic, they might be confused, but once they go through the PowerPoint, I'm sure they will be slowly understanding everything slowly. Okay.
Okay.
I think we should conclude today's discussion. Okay, good night, everybody.
Okay.
Next
So
week,
tomorrow we
if
have no class. Okay.
tomorrow we have no class, yeah.
Okay.
Today
Okay.
it has. Okay.
Actually,
Okay.
I'm not so much informed about these things. So it is a very short time I have actually prepared this PPT. But I try to make it understand, because the common and also some uncommon pathology I should including in my PPT. So thank you for patient sharing, and also Shirish. Hopefully we can conclude. So everyone, if there is any question, just also ask in our website. There is one chat box maybe, so we actually try to answer the all questions. So thank you.
Okay.
Good night.
Good night, Milton. Good night,
Good night.
everybody.